obesity. طيب, the objective of this presentation is going to cover the following point. There's some sort of introduction, epidemiology of obesity, diagnosis, how we diagnose it, cause and risk factor, obesity comorbidity, obesity assessment, and treatment, prevention, and one slide about metabolic syndrome. So epidemiology, pediatric obesity is an exponentially growing global public health concern. United States, children and adolescents aged 2 to 19 years in 2017, 2021, according to CDC, the prevalence of obesity was 19.7 and it affected about 14.7 million children and adolescents. Obesity prevalence was 12.7 among 2 to 5 years old, 20.7 among 6 to 11 years, and almost 22.2 among 12 to 19 years. And you see very clearly that adolescents are more affected. And not only that, even 2 to 5 years old, even us at our clinic, we see a lot of kids, their age 2 to 5 years, they're having obesity. In 2019, estimated 38 million children under the age of 5 were overweight or obese. Overweight, obesity are now on the rise in a low and middle income countries. طبعا يعني it is a real problems, particularly in urban setting. In Africa, the number of overweight children under 5 has increased by nearly 24% since 2000. يعني الناس بتفتكر in Africa only we have the issue of malnutrition, but again the obesity is a real problem. طيب, I searched in the literature looking for the obesity prevalence in Sudan. I found one of the studies done in 2012. The other study is very small sample size. This is a study done in 2012. School children at Al-Khartoum. Almost they investigate 1,138. They find that the obesity is around 9 and overweight is around 10.8. Right. Body mass index, it is a measure of the body weight adjusted for height. It's a useful tool to assess body fat. Body mass index is defined as the weight in kilogram divided by square of height in meter. A body mass index that plot in appropriate gross chart is a method to diagnose overweight or obesity in children and adolescents their age 2 years and above. And the body mass index level correlate with the body fat and concurrent health risks, especially cardiovascular risk, and it predicts future obesity as well as morbidity from obesity. Like how we diagnose obesity, what are the criteria we use? If you look for these weight categories, as we know, if the child weight body mass index is below the 5th percentile, this is an underweight child. And if the child body mass index between 5/5 and 85th, this is a normal child. And if between 85th and less than 95th percentile, this is overweight. And if the body mass index above the 95th percentile or above, this is obesity. And there is recent classifications, a body mass index of 120 or more and less than 140 of 95th percentile. That means a body mass index of 35 kg per meter square. This is classified as class 2 obesity, and class 3 if the body mass index is 40 or more kilogram per meter square. And this is recent classification. It is clinical practice use when we are talking about the medications and pediatric setting. So if I have a 10 years old child and his body mass index is here in this area, so the child is obese, and if it's in yellow area, he's an overweight, and if it's in green area, this is a normal child, and if below that, this is an underweight child. For children their age less than 2 years of age, be diagnosed as obese if the sex-specific weight for recombinant links is 97.7 or more percentile on the World Health Organization chart. And if you look for the equation 97.7, it is equal to 2 Z-score. And if you see this is the gross chart of the WHO weight for links. And if the child weight for links like this is above the 2 Z-score, that means the child is having obesity. And why it's of concern? Because as I mentioned before, currently we see children even in age less than 2 years and they have obesity, so you have to know which centile and which cross chart we are going to plot on. Type the cause of obesity. Obesity, the common cause, as all of us we know, it is an environmental factor, or we call it exogenous obesity. So the current eating habits, people currently they eat more fast food, more sweet beverage with less fruit and vegetables. And again, the physical activity and sedentary behaviors that promote energy imbalance. Currently, we saw a lot of children, or almost most of our children, they spend a lot of time in the screen time, digital games, tabs, telephones, and others, and less hour on the physical activity. The rare causes is monogenic obesity. This is a single gene defect, namely MC4 receptor deficiency, BOMC deficiency, leptin deficiency, leptin receptor deficiency, or obesity associated with certain syndrome like Prader-Willi syndrome, Bardet-Biedl syndromes, and endocrine causes, Cushing, hypothalamic lesions. Again, this is all is a rare cause, but as endocrinologists, commonly we see children in our clinic who are obese because people they think most likely is having an endocrine issue, but really it is rare. But we have, as for you, you have to know what other cause rather than the exogenous obesity. You have to think of it. The comorbidity of pediatric obesity, as we know, the pediatric obesity can cause a lot of problems, affecting many systems psychologically, pulmonary, gastrointestinal, renal, musculoskeletal, endocrines, cardiovascular, neurological, and endocrine, mainly type 2 diabetes, or sometimes they have precocious puberty, premature puberty, peripheral one, and polycystic ovary syndrome, with hypogonadism in children who's having another problem. So all the system is going to be affected, and this is why currently we are talking about pediatric obesity because of this possible complication if we are not interfere early. Assessment of obese child, how we assess obese child. So if you come across obese child, how we are going to tackle the problem of this child. The most important thing when you are assessing the obese child, you have to assess the medical risk, the behavior risk, and parent readiness to change. Medical risk, behavior risk, and parent readiness to change. Why the parent readiness to change? Because sometimes you offer the parent the information and something to do with their child who's obese, but the parents themselves, they don't think their child is having problems. So this is very important. You have to check it. Type, what is the medical risk? What we mean by the medical risk? Risk of future or persistent obesity. If the child, his parent having obesity, so the risk of the child to have obesity or to have a persistent obesity to adulthood is very high. The other point, risk of future obesity-related complication. If there is family history of type 2 diabetes, insulin-resistant, childhood type 2 diabetes, cardiovascular disease, hypertension, hyperlipidemia in the family, so the risk of this child to develop obesity comorbidity is very high. A third point is identification of current obesity-related medical condition, and how we can identify that by the following. You have to do history, looking for the complications, and you have to do examination, looking for the complications, and you do certain lab investigation for obesity comorbidity. So this is the medical risk. What is the behavior risk? The behavior risk, you have to ask about the current eating habits. The current eating habits, we mean fast food. How many times this child eat fast food? What about the sweet beverage? And what about fruit and vegetable? How many times he eats fruit? How many times he eats vegetables? So this is very important information, because if you gather it at the beginning, so you can give good advice for the parent. Physical activity and sedentary behaviors that promote energy imbalance. Screen time. Really, currently we are starting obesity clinic in a hospital. One of the universal problems, the screen time. Kids is spending hours and hours, almost like 7, 8, 10 hours in screen time. When we say the screen time, we don't mean the academic activity screen time. No, out of the academic activity screen time. Hour of physical activity, most of children, they are not spending any time of physical activity. So this is important information you have to gather at the beginning. Type evaluation in the history, you have to ask about the age of the onset when this obesity started. Why for? Because children who develop obesity before 5 years of age or as early as 2 years old, it can give you a clue to specific diagnosis, especially you have to put in your mind the syndromic obesity and the genetic obesity. Diet and eating behavior, as I mentioned, the behaviors, physical activity, school and social issue, because these children who have obesity is having an issue at the school. Sleep problems and daytime somnolence. This is again, it gives you clue to the complication of obesity, obstructive sleep apnea, symptoms suggestive of diabetes, any monetary irregularity, especially in adolescent girl, again, symptom of hypothyroidism, family history of obesity, as I mentioned, and family history of early heart disease. When you examine a child who's obese, you have to measure and plot the following. The height, why it's important, because if the child is obese and his height in the higher side, this is most likely you are dealing with exogenous obesity with very rare exceptions in MC4 receptors. But the common cause of an obese child and his height in the higher side, the first impression, this is an exogenous obesity. And if the child is obese and his weight in the lower side, his height in the lower side, then you have to think of pathological issue. Again, the weight and the body mass index, the weight circumference, you have to check the blood pressure. It is very important. You have to look for the dysmorphic feature. You have to look for sign of Cushing, thyroid issue, acanthosis nigricans, sign of polycystic ovary syndromes, and you have to assess puberty. So this is the important point you have to look for. For sure, you look for musculoskeletal examination for any deformities. This is the important point in examination. So there is certain features suggest genetic syndrome or suggest a pathological issue. If the child is short, having severe unremitting obesity, and his obesity started very early, before 2 years of age, he's having some sort of dysmorphic features, he's having learning disability, if the child is more than that, having hypotonia, hypogonadism, skeletal abnormalities, other organ abnormalities, this can give you a clue. This child is not having just an exogenous obesity, he's having pathological problems, and you need to look for the cause. Investigation, when you come to investigations, you have to categorize your SOT. You have to do investigation looking for the cause, and you have to do investigation looking for the comorbidity. Investigation looking for the cause, endocrine cause if there is clue. So it is not routinely we need to screen children who are obese for endocrine cause, doing thyroid function and other. No, if there is from the history and examination there is clue for endocrine cause, then you can check the endocrine cause. Consider the genetic testing. Certain group of children, especially those who are less than 5 years, of having obesity started very early with very rapid unremitting with special food-seeking behavior, then this group of children you can think of a genetic testing for them to exclude monogenic obesity. Investigation for comorbidity, it is very important to investigate for dysglycemia, prediabetes, and diabetes. Dyslipidemia, non-alcohol fatty liver disease, polycystic ovary syndromes, and don't forget to investigate for obstructive sleep apnea if there is history suggestive of that. So this is the investigation you need to do. If you are working, like in the situation in Sudan, you are working outside of the endocrine center in a rural hospital or hospital outside as I mentioned, the endocrine center. So there is certain indication for referral to secondary care. If from the history and the examination, there is possible secondary cause for the obesity, short stature, dysmorphic feature, learning difficulties, these children need to be referred for the higher center or secondary care on the endocrine center for further evaluation and investigation, and most likely they need multidisciplinary team. Presence of comorbidity, if the child is obese and having comorbidities, again, he needs to be referred for a center where there is a weight management clinic or a team that can deal with it. Hypertension, disorder of eating, because those who have disorder of eating, poor body image, as we know, there is a lot of psychiatric problem related to obesity and anxiety, depression, eating disorder. This group of children, if you start to give them advice about decreasing the weight, you're not going to improve. So depression and anxiety, obstructive sleep apnea, orthopedic problems, okay, because if you don't treat the orthopedic problems, probably the child is not going to have physical activity. Biochemical evidence of dyslipidemia, impaired glucose tolerance, liver dysfunctions, and evidence of PCOS. So if you have any evidence of comorbidity, so you can refer the child to the center where they can deal with these problems. Treatment of children and adolescents with overweight and obesity. It composes of 4 stages. Usually we have 4 stages of treatment. And the stage, again, it depends on the age of the child, the body mass index of the child, and present or absence of the comorbidity. And the 4th thing is there any health risk, behavior risk, or medical risk? Management of obesity, in general, it needs teams. Doctors, health coach, dietitian, psychologist. And again, it needs the school, the community, all these people need to be involved in the management of obesity. Refer in obese child with possible secondary cause, secondary care, as I mentioned, and refer those with associated comorbidity to specialist unit for a specific management. Lifestyle modification with motivational interviewing, this is very important intervention. So the stages, generally you have 4 stages. Stage 1, stage 2, stage 3, and 4. So stage 1, this is usually 1 and 2, or 1 can be done at the level of the primary health care if you have a good primary health care, because usually we call it prevention plus, just promoting basic health lifestyle and improving activity and eating habits. Stage 2, if the child is not improving, you can move to stage 2. How usually we need around 3 to 6 months to move to the second stage, structural weight management, and usually this is done at the level of secondary care or sometimes at the level of the primary care if there is good setting. It is prevention plus increased support and structure, plan reinforcement with behavior therapy, motivation interviewing, monthly office visit, eat planning created by dietitian. The stage 3, it needs comprehensive multidisciplinary interventions, and this is usually done at the level of secondary care. And the stage 4 is a tertiary care intervention, only approved for adolescents, because this group of children, if they have certain criteria, they may need a pharmacological intervention, and if the pharmacological intervention not work, then you can think of bariatric surgery. So this is the stages of intervention for obese children. The most important is for treatment of childhood obesity: healthy eating, physical activity, limited screen time, increased fit time, and more sleep. The more sleep. And the most important, you have to memorize it, is a rule of 0125. What is the rule of 0125? A rule of 0215 is 0 sugary drink. 0 sugary drink, more water, 1 hour or more of physical activity, 2 hours or less of screen time out of academic activities, 5 or more fruit and vegetables per day. So the rule of 0125 is the golden rules. It is very important in the intervention plus, and it is very important in the prevention of obesity. So lifestyle modification, as I mentioned, must be intensive, age-appropriate, culture, and financial sensitive, and family centers. Family center, because if you talk about the family, tell them their child have to do 1, 2, 3, 4, and the families themselves, they bring soda, they bring a lot of sweet and bring everything, and they tell the child, no, you don't eat because the doctor said you have to be avoided completely from this sweet beverage and from this fast food. So it must be family centers. financial sensitive، خاصه مثلا عندنا نحن الوضع في السودان، يعني ما تقدر تقول له والله انت اكل سمك واكل وهو اصلا ما قادر يشتري رغيف اصلا. ف intensive age appropriate culture age, because the adolescent, as we know, we have a specific deal with the adolescent. So when we are talking about the lifestyle modification, as I mentioned, the diet, the physical activity, and behavior modifications. Dietary modification, what we mean by it, decreased consumption of fast food, add table sugar, high fructose corn, high fat, high sodium, processed food, eliminate of sugar sweetening beverage, increase consumption of whole fruit rather than fruit juice. People usually they drink rather than eat, but eat is better than drink. Increase intake of dietary fiber, fruit and vegetables, and encourage timely, regular meals and avoiding frequent snack. Portion control education is very important again. Physical activity, we need minimum of 20 minutes, and then you upgrade to the goal of 60 minutes. And you have to limit an academic screen time to 1 to 2 hours, as I mentioned, and decrease other sedentary behavior such as digital activities. وطبعا الآن كل بيت فوقه بلاي ستيشن، ودي واحدة من المشاكل. أي طفل عمره 5 سنوات عنده تلفون iPhone 13 Pro Max. طيب, the goal of the management is either weight maintenance or weight loss. So when you are dealing, what is the goal? The goal is either to maintain the weight of this child rather than to reduce the weight, or you need to reduce the weight. Maintaining the weight or reducing the weight, this is depend on the age of the child, the body mass index of the child, and the medical risk. So those who are adolescents with severe obesity, having medical risk, for sure we need to reduce their weight. And those children who are having overweight and their age less than 10 years, usually we need just to maintain their weight. And if we maintain their weight because they are growing, the body mass index is going to drop down. Time. Pharmacological therapy for children and adolescents with obesity, we offer only this after formal program of intensive lifestyle modification has failed to limit the weight gain or to ameliorate the comorbidities. And people are currently talking about children whose age 12 years or more with a body mass index of 95th percentile or more with comorbidities, or those whose body mass index is 30 kg per meter square without comorbidity. And there is a list of drugs. Some of them they are FDA approved for children, and some of them they are not FDA approved, and people they use it off label. So the FDA approved is Orlistat, and all of you know the Orlistat is one of the medication early on used for treatment of pediatric obesity. The problem of it is the GIT problems. The recent medication approved for treatment of pediatric obesity is the liraglutide, and the liraglutide one of the incretin hormones, and it is GLP-1 glucagon-like peptide. This is a recent one, and this is published. This is published on Endocrine, Diabetes, Obesity 2000 February recently. Type. So this is the medication, and as I mentioned, these medications only for children who have certain criteria and whose age is 12 years, and you do with them intensive lifestyle modification, but they fail to show any improvement. So you can try this medication. But the important point, the clinician must know it. The clinician should discontinue medication and reevaluate the patient if the patient does not have more than 4% reduction of body mass index. Body mass index is the score reduction after taking the anti-obesity medication for 12 weeks. That means 3 months at a medication full dose. So if you give the child the medications and you give the full dose with the lifestyle modification, but no improvement, so you have to move from this stage to the other stage. There is a lot of controversies regarding bariatric obesity, the indication, the criteria for pediatric obesity. This is in American Society of Pediatric, Metabolic, and Bariatric Surgery Guideline 2018. This is the latest one. Indication and contraindication for adolescent metabolic and bariatric surgery. Indication for adolescent include if the adolescent, his body mass index is 35 kg per meter square or 120 of the 95th percentile with clinical significant comorbidity condition such as obstructive sleep apnea, type 2 diabetes, liver issues, or the child is having body mass index of 40 or more kilogram per meter square. Again, this is another indication for bariatric surgery. So the child if the child having this criteria, and you try with him the lifestyle modification, you give him the medication, and there is no improvement, so you can offer them this bariatric surgery. But for sure, the bariatric surgery for pediatric, it needs to be done in a center with good volumes and good experience. There is certain contraindication for the adolescent pediatric surgery, a medically correctable cause of obesity. If a medical correctable cause of obesity, so this is you have to do it to correct it by the medical treatment. And ongoing substance abuse problems, medical, psychiatric, psychosocial, or cognitive conditions that prevent adherence to postoperative dietary and medication regimen, or current or planned pregnancy within 12 to 18 months. وطبعا ده واحدة من contraindications. So this is for a bariatric surgery. طيب, prevention, how we prevent obesity, health education program about lifestyle modification, diet, physical activity, behavior change, targeting communities, schools, families, and children. Behavior modification program, encourage breastfeeding, calculate, plotting, reviewing child or adolescent body mass index percentile at least annually during well child or sick child visit. So whenever you come across a child, check his body mass index, take history. If he's having overweight, counsel them, give them advice not to go to obesity. Type. And as I mentioned at the beginning, the most important rule is 0-1-2-5 in the prevention of obesity. So 0 sugar, 1 hour of physical activity, 2 hours or less of screen time, and 5 or more fruit and vegetables. So you can write in the chat, look for this gross chart. This is an obese child, and you given this gross chart for him, you plot his weight and height. So what do you think? Is this child having a pathological obesity or exogenous obesity? You can write on the chat. So the first response by most of people, they said exogenous. That is good, excellent. And what about this one? What about this one? Is it exogenous or pathological obesity? So most of people that write pathological obesity. This is just simply how useful the gross chart if you plot the weight and the height of the child. Very simple. It can give you a clue about the possible cause of the obesity. طيب, metabolic syndrome, according to the International Diabetes Federations, it's diagnosed for children. Metabolic syndrome is diagnosed for children if the children age between 10 to 16 years have central adiposity and two of the following: triglyceride level, specific levels. So for sure, this is not, you are not going to memorize this. It is available everywhere. You go to Google and write it. It is available. And again, WHO criteria. There is WHO criteria, and there is other classification. But is that just this is two of the classifications. Type take-home message from the obesity presentation: prevention of pediatric obesity by promoting healthful diet, activity, and environment should be the primary goal, as achieving effective, long-standing result with lifestyle modification once obesity occurs, really it is difficult. So you have to work more on the prevention. Comorbidity are common, and screening for it should be applied in a hierarchical, logical manner for early identification before more serious complications happen. And again, 0125, it is a very useful one. Thank you very much for your time. I end the first session of my talk. Then we can move. If there is question, we left the question to the end. Now we can move to the second part of the talk. Any suggestion, Amir or Dr. Muhammad, or I can move?
Yes, Dr. Bashir, you can. You might proceed to the second section.
Okay, thank you. Does it appear, Ahmed, or not yet?
Yes, now it is full screen. Yes,
full
you
screen.
can proceed.
Okay, thank you very much.
Aywa, you can proceed.
Yeah. طيب. The objective of these questions, we just try to check your knowledge after a lot of information you received from our previous colleague. So, inshallah, by the end, we demonstrate medical knowledge and clinical skill across most of the major area of endocrine, and you can apply your knowledge and skill in diagnosing, managing, and treating a wide spectrum of endocrine disorders. And inshallah, you will be prepared for the exam. So this is the first question. The first questions: you come across 6 days old newborn is brought to the emergency with seizure. He is full term, formula fed with unremarkable examination. Lab result showed the following. So which of the following is the most likely cause of his hypocalcemia? I bring this slide because for you it is very important to know how to interpret the bone profile. So what is which of the following is the most likely cause of his hypocalcemia? The answer is going to be in the chat. I will follow the chat. I have almost like 16 questions. So if you quickly answer, it will give us chance So the first one respond, he said vitamin D. Some of them they said hypocalcemia. I will give just like 30 seconds for the answer, and then I will clarify the answer. Some people they say C. Okay, so I can conclude. Some of you they said D. Some of you, most of you they said C. Yeah, different answer. So this is a very important slide. Please just concentrate. What is the problem of the child in this slide? This child having low calcium. So the calcium is low and the phosphate is in the higher side and the alkaline phosphatase is normal. Am I right? The PTH is normal. Having normal PTH. Urea is normal and the magnesium is normal. So you don't have level of vitamin D. The most important point is whenever you have a child with a low calcium, the calcium is low and the phosphate is high. So your differential diagnosis is going to be a low calcium with high phosphate. Whenever I have, because usually in the ER, usually we ask for bone profile containing calcium, phosphate, albumin, magnesium, usually with an alkaline phosphatase. So whenever you have a low calcium with high phosphate, your differential diagnosis is going to be this child is either having BTH, having parathyroid related issue, or the child having kidney issue, or the child is having magnesium issue, because this is the three differential of somebody is having low calcium with high phosphate. So if you apply this, in this case, vitamin D is not a probability. Why? Because if you have vitamin D deficiency, the alkaline phosphatase is going to be high, unless the child is malnourished. And we are not dealing with a malnourished child. So vitamin D is not probability. Why? Because in vitamin D deficiency, the alkaline phosphatase is high. Done. Type. So is it decreased calcium intake? In a child with decreased calcium intake, the calcium is going to be low, the phosphate is going to be sometime in the higher side, but the alkaline phosphatase is going to be high, and the alkaline phosphatase of the patient is normal. So I have low calcium, high phosphate, the alkaline phosphatase of the patient is normal. So once the alkaline phosphatase is normal, I rule out kidney issue, even I don't have urea. Because if I have kidney issue, the alkaline phosphatase is going to be high. So kidney issue is removed out. I remain with parathyroid and magnesium. Magnesium is normal, so it's not probability. So we are dealing with parathyroid problem. Is this pseudo, hypopara, or hypopara? It is not pseudo. Why? Because if it's pseudo hypo, the PTH is going to be high. So I have a normal PTH. So the diagnosis is hypopara. The diagnosis of this patient is hypoparathyroidism. In hypoparathyroidism, you have to keep in mind the PTH may be normal or it may be low. So if it's normal, it is an inappropriate normal, because at this time I expect the PTH to be in the higher side because the calcium is low. So to sum up this slide, because to me it's an important slide, whenever you have a child with low calcium, high phosphate, look for the alkaline phosphatase. If the alkaline phosphatase is normal, kidney issue excluded, we left white PTH problem and magnesium. If magnesium is normal, we left the PTH, and then the PTH is either the PTH is high or normal or low. But the second probability, if I have low calcium, a child with a low calcium, and his phosphate is low, alkaline phosphatase is high, as I mentioned before, this is most likely we are dealing with the child having vitamin D deficiency. So this is important. You have to know how to interpret the bone profile. Type the second case, this is a 10 years old with recently diagnosed as grave disease, has a history of excellent compliance on numericazole 5 mg 12 hourly. Which of the following would be the initial laboratory indicates that the dose should be decreased? Which one? Is it the low free T4 or the high free T4, or TS previously low and now mildly normal, or a TSH elevated to 10? Chat. What is the answer? Type. Excellent, excellent. Some of you they pick the right answer. Whenever you have a child on numericazole having grave disease, usually we start them in the higher dose, and then we keep following the thyroid function. The first thing you have to look for, if because initially the T4 is high and the TSH is low. So whenever the T4 come back to the normal level, you start titrating the dose. So the answer for this patient is low free T4, because high free T4 will not reduce the dose. TSH previously low, now mildly normal. You don't wait till the TSH to change. Usually we interfere by reducing the dose before the TSH, because the latest thing to change is the TSH. So the follow-up of somebody is having Graves on treatment is by looking for the free T4. Whenever the free T4 normalize or getting low, you have to reduce the dose. What is the mechanism of action of methimazole? What is the methimazole? Methimazole is byproduct of neomercazole, because in Sudan you have neomercazole. So how it works? How it works؟ السؤال ده انا سمعته، انا حاضره في المحاضره. انا في المحاضره كنت قاعد حقت دكتور الوسيله. انا حاشتكيكم للوسيله، حاشتكيكم للوسيله، لو الوسيله ماشي حاشتكيكم له طوالي. اقول للناس زي كانوا نايمين في المحاضره بتاعتك. طيب اغلب الناس جاوبت الاجابه A اللي هي inhibit peripheral conversion of T4 to T3. The peripheral conversion, it is not the action of methimazole or neomercazole. This is action of proprietary. So the neomercazole or the its byproduct methimazole, it works by inhibiting the synthesis of T4 and T3, because it inhibits the enzyme thyroid peroxidase. So by doing so, it inhibits the organification and coupling of iodine to tyrosine residue. So the answer is B. انتوا اغلب الناس جاوبت A. ف it is not the answer. The conversion usually it is action of proprietary C, because it inhibits the synthesis and it can prevent the conversion. طيب, you are called to see a result of newborn screening, 15 days old baby whose TSH was 65. انت الدكتور الحكيم الكبير دقوا عليك تليفون قالوا لك يا اخي دي النتيجه بتاعت الطفل اللي عملوا له سكريننج، وان شاء الله كده يكون عندنا قريب في السودان نيو بورن سكريننج، لكن انت you have to know everything. طيب, فالريزلت حقته كانت 65. Let us say and this is cord blood sample, because usually in newborn screening we have a cord blood and heel prick. So this is a cord blood sampling of a child, and the result come back at day 15, which shows a TSH of 65. So what is the next step in his management? يلا سريع يا جماعه. كويك. كويك. ممتاز. الناس جاوبت، يعني الناس لحد الان جاوبوا الاجابه صح. So in this situation, whenever you have a newborn screening result, which is significant because in Saudi Arabia we have a cord blood screening. So the cutoff is 30 to 60. Below 30 is normal, and above 60, between 30 to 60 is borderline, and above 60 is significant. So the action is to call the parent back, assess the child, took history, examining the child, and you have to took confirmatory sample, TSH and free T4, and you have to start thyroxine immediately, especially in our situation. Start immediately, waiting for the result. Tell the parent very clearly, your child must receive these medications. This medication most likely doesn't have any harm for your child. The result we expect it to be soon, inshallah, within 2-3 days. And when the result come back, call the parent, and you have to know what is the criteria for diagnosing hypothyroidism in a confirmatory test. Yani initial screening sample, when you send for confirmatory, the result, the confirmatory test for hypothyroidism. The definition of hypothyroidism in the confirmatory venous sample is if the TSH is high and T4 is low, this is 1. Again, the second definition, if the TSH is more than 20 with a normal free T4. If the confirmatory test showed a normal free T4 with high TSH more than 20, again, this is a diagnosis of hypothyroidism. The third probability, if the TSH between 60 and 20 and the free T4 is normal, again, this is a controversy. Either you treat or you can wait for next week, especially if the child age is 3 weeks, you can wait for another week. So this is in regard to congenital hypothyroidism. طيب, نمشي شويه خلاص نخلي الثايرويد. This is a 9-year-old boy present to emergency department with history of polyuria for 1 week. His exam showed a normal child and his lab results showed RBS of 230. What is the most likely diagnosis? Is the child having diabetes, pre-diabetes, stress hyperglycemia, or we are dealing with a normal child? سؤال في غاية البساطة. طيب. طيب, good. Excellent. Most of people are answering the right answer. The right answer is diabetes. Because this child is having symptom and his random blood glucose is more than 200, and as you know, the criteria for diagnosing diabetes in children, if there is symptom with a fasting blood glucose of 126 or more, or with a random blood glucose of 200, it's not stress hyperglycemia, because usually in stress hyperglycemia we don't have symptom, just we have high blood glucose more than 150, which come back to normal after removing of the stressful condition. Excellent. طيب. Second question. This is a 9-year-old boy brought to ER with history of polyuria and polydipsia for 2 weeks and vomiting for 6 hours, no fever. Exam notable for acidotic breathing, dehydration, normal glycemic scale. Is having high RPS, severe acidosis. He treated according to hospital protocol, given insulin infusion 0.1 unit per kg. 5 hours later, you reassess him and you find the following. Be very practical. This is a practical point of managing DKA. So this patient is having DKA for sure. Starting the management, you are assessing your patient. 5 hours later, you come and you find the following. Patient is tachycardic, capillary refilling time is less than 2 seconds. His pH is 6.9 and his bicarb is 3. Glycemic scale is 10-14 and his RBS is 450. So, and no fevers. So what is the best action in his management? طيب. What is the best action? طيب. I congratulate Sarah Arua. This is the people so far giving the right diagnosis. Sarah Arua. طيب. The answer is, طيب, what is the problem of this child? My child, when I reassess him, his capillary refilling is less than 2 seconds. So this child is not needing fluid. Because if the acidosis is not improved after 4 hours, you have to think of the following. Is the problem related to fluid? Does we need more fluid? Or this child may having hidden sepsis and he need antibiotic for that. Or the child having issue of insulin. يعني دير الثلاثة probability. Sometimes in a child is taking insulin for a long time, you can think of hypercholoremic metabolic acidosis. This is not the case. But usually this is the way of thinking. Is it fluid issue? Is it sepsis? Or is it insulin issue? طيب, the child capillary refilling is less than 2 seconds. So the probability of giving fluid is not there. So it is not fluid issue. Start antibiotic for sepsis? No, before it starts antibiotic for sepsis. The blood glucose of this child initially is 490. And now 450 after 5 hours. So this blood glucose is not dropping significantly. Because the target, what our target, when we're starting managing the DKA, our target is to drop blood glucose by 50 and less than 90. يعني 50 to 90 milligram per hour. So this patient he need intervention since the first 2 hours because the blood glucose does not drop down significantly. And whenever the blood glucose does not drop down significantly, check the dose, check the calculation, check the line. If everything is okay and you are in 0.1 unit, for sure you increase the dose by 20%. So the right answer is to increase the dose. This is very practical questions. طيب. The last question in diabetes. Ahmed, known case of diabetes mellitus. This is an OBD management. Ahmed is known case of diabetes type 1 on basal bolus, يعني بياخد على كده جلارجين مع نوفورابيدول. Regamin, his mother concerned about early morning hypoglycemia. His mother's concern is about early morning. Sorry, it is not hypoglycemia. She's concerned about early morning. Yes, early morning hypoglycemia. His home blood glucose record showed. So this child at 7 a.m. his blood glucose in the higher side. At 9 a.m. is normal. At 1 p.m., 3 p.m., 9 p.m., 11 p.m. So this is a time, bedtime is normal. Then at 3 a.m. is having hypos, and then early morning hyper. So what is the best intervention you are going to do? تمام. طيب the problem of this child is having hypoglycemia at early morning at 3 a.m. and hyperglycemia in the morning. Hyperglycemia. This is what we do. What we call this phenomena. What is the phenomena? What is the name of phenomena? This is Mujo phenomena. Excellent. Yeah. So the action is going to be you have to reduce your long-acting dose. That means the glargine. So you have to reduce the glargine dose. Type 2 diabetes, again, currently it is a real problem because now we are dealing with epidemic of obesity, so you have to know something about it. You are evaluating 11-year-old boy who brought to hospital because of he is obese and his parent noticed nocturia. His father known case of type 2 diabetes. Exam showed obese child with a body mass index above 97 percentile, calciosis nigricans. His random blood glucose was 300 and urine showed 2 crosses of sugar without ketone and the A1C is 9.7. What is the best option for his management? يلا سريع. طيب okay, excellent. Most of you they said the right answer. طيب in patient with type 2 diabetes, usually the presentation is one of three. The presentation in type 2 diabetes is one of three. Either the patient present and discover asymptomatic with an A1C less than 8.5 and he's asymptomatic with just having hyperglycemia without symptom, or he's having A1C more than 8.5 even with acid with ketone without acidosis. This is the second probability. Or the third probability, the patient presents with DKA. So now our child in the second groups, A1C more than 8.5 and his blood glucose is high with no ketone. So this group of children, you need to start them on basal insulin plus lifestyle modification plus minus metformin. You can start metformin or you can add metformin later on. But if the child presents with an A1C less than 8.5 without severe hyperglycemia, then you can start the metformin and lifestyle modification from the beginning. The third group who present with DKA or those who present with DKA, this group you start them in basal bolus, rapid and long-acting insulin till clearance of ketone. And based on latest American Diabetes Association guidelines, in any obese child who present with diabetes, you have to do antibody, and the antibody is going to give you the line where to go to add to continue at the type 1 or not. طيب انا افتكر السؤال ده هو عن الهايبوغلايسيميا او دكتور بشير وسيله يعني he cover all the hypoglycemia with many cases. I can skip this question. Going to the gross chart. So this is gross chart of different patients who came to you because of short stature. Look to the gross pattern and tell what the most likely diagnosis. What is the diagnosis of this one? What is the diagnosis of this one? So people they given different answers. Some people they said, so what if you look at this guy, his age is 3 years, his gross is dropped down and keep constant. Constant, that means his normal gross velocity. At the end, he reaching the target height, but the target height itself is below the certain type. So the diagnosis this child is having genetic short stature or familiar short stature. So genetic or the other term is familiar short stature. So this is a familiar short stature or genetic short stature. So the second child. So what is the diagnosis? What is the diagnosis? Okay. What is the diagnosis of this one? أنا ما عايز واحد يغلط في السؤال. Yeah, this is constitutional delay of growth. So this is a growth chart, give you a picture of constitutional delay of growth. A child is growth at the lowest level constantly, and then at the puberty he catch up his target height. So this is a constitutional delay and constitutional delay and familial short stature. This is the two common cause of short statures come to the clinic. What about this third one? What is the diagnosis based on this cross chart? Excellent. Most of you, they mentioned celiac. Yeah, it is celiac disease. Based on this option, yes, this is celiac disease. Why? Because this child, his weight is more affected than his height. So usually in a malnourished child or in a child having an issue causing him to be a malnourished, like celiac and other disease, usually the weight is going to be affected first and then followed by the height. Excellent. Mumtaz, mumtaz. طيب, the following are approved indication for growth hormone in pediatrics, except easiest question. Different answer, but most of you that get small for gestation as it is one of the approved indications. Idiopathic short gestation approved, Prader-Willi syndrome, Turner syndromes, Rosa-Silva syndromes, kind of having chronic kidney failure on dialysis. This is a group of children having approved for growth hormone. So IGF-1 deficiency, it is not indication for growth hormone because there is that this is indication to give IGF-1 itself. طيب يا أمير محمد كيف الوقت؟
والله حسب احنا we just need to give them a break for عشاء prayer depending on the time. وبعدها we continue.
Because now أنا الآن في يعني just finished 50% of my slide. Still I have
this is quite beneficial to them, and I think إنه يعني أنا I can run through the adrenals quickly. ما لازم to emphasize too much. الquestions بالنسبة لهم أهم.
تمام.
لكن نسمع رأيهم هم الآن.
Let them chat, please chat in the.
لا للصباح ما قال معك للصباح.
تمام.
طيب الآن متى وقت صلاة العشاء عندكم؟
عندنا نحن في المدينة ولا عندهم في السودان؟
عندهم هم.
اسمع انت سيد العارفين، لكن العشاء يعني ممكن كان اتاخر شويه، ما اظن في مشكله ولا شنو؟
لما في واحد بيكون جنبهم مسجد يمكن جنب البيت وعايزين يصلوا كذا بس عشان ما يفوتوا يعني صلاه لسه. طيب اتفضلوا نبهونا لما الصلاه تجي، خلي بشير يواصل ان شاء الله.
طيب
اصلا we will break between my talk and بشير يعني ننتهي بشير we give you a little bit of a break.
تمام. So I try to go quick ان شاء الله.
لا go take your time.
طيب تمام. You are a specialist on call and you are asked to see 15 days old baby home delivery. His parents are concerned about his abnormal genitalia, poor feeding and lethargy. His examination showed hyperpigmented baby with compensated shock. His febrile and has genitalia abnormality. طبعا يا شباب انا ما عارفين الحاصل، مستحيل يجيبوا لك ستريت فورورد كيس كده. بتذكر زمان في المجلس ده هسه كده ستريت فورورد، لكن انا I have يعني specific message I need to deliver. So his febrile, his genitalia is ambiguous. So if you look, this child is hyperpigmented and has genitalia showed from far away كده there is a phallus and with some imagination develop a scrotum which is empty. But طيب when you ask to examine a genitalia of such child, for sure you the first thing to do is, for example, you have to look at the child is dysmorphic or not. You have to look for the skin of the color of the skin, the child hyperpigmented or not, and then go directly to genitalia. For sure, Sahar, she covered this point. So what is the most likely diagnosis? Excellent. خلاص تمام. كل الناس عارفين خلاص. The diagnosis most likely you are dealing with CH. So what investigation are going to request? لأن السؤال ده ممكن يجي في الأورال exam. What investigation? what I would like to do, I would like to arrange your SOT. Abdominal ultrasound, electrolyte, pelvic ultrasound, RBS, 17 hydroxyprogesterone. So whenever you ask this question, you have to arrange your SOT in this way. Like what you mentioned, all is true. But usually arrange your SOT in this way. You need investigation. Look, this is CH most likely. So we need investigation looking for the complication of CH. and I need investigation to confirm my suspicions. Is this cat really is having CH or not? And again, the investigation I have to do to confirm my suspicion, it is two parts: blood investigation and imaging investigation. So this is the way you arrange your sort. So the initial thing, looking for the complication, for sure, I check if I have the VPG, I will do the VPG. I will do blood urea and electrolyte for sure. I will check the blood glucose for sure. Someone can say I can check, I do septic screening, accept it. So this is the investigation looking for the complications. Investigation looking for the confirmation of the suspicions. I have to take blood sample for testosterone, and if I have facility, I can do the hydrotestosterone again. I will check the cortisol. I will check the ACTH for sure, and then 17-hydroxyprogesterone. This investigation cannot be done at that night if you see this guy at midnight, but you can take the sample, ask the lab to centrifuge the sample and keep it. And then imaging, you order for pelvic ultrasound, looking specifically, you have to mention what are you looking for in the pelvic ultrasound. You have to ask about looking for the ovaries and any absent or present or the gonad, exactly the internal organ you have to look for. But you have to ask the ultrasonography exactly what are you looking for. And for sure, we don't forget to check the karyotype. So this is the way you arrange your sort in regard to the investigation. Outline your management plan, and I would like you to arrange it in just. This is a broad question, so I expect a broad answer. طيب, hydrocortisone, yes, ABC for sure. Yeah, for sure. This patient, I assess the ABC for sure. And if the child is having hypoglycemia, for sure, I will give him dextrose, and then I will give him a hydrocortisone for sure. تمام. ممتاز. Abdullah, ممتاز. The result of investigation showed low cortisol, high potassium, low sodium, and high 17-hydroxyprogesterone and testosterone. Regarding the chemosteroid synthesis, deficiency of which of the enzyme is not likely responsible for this laboratory result. ده سؤال هدية. طيب. تمام. في واحد قال دي ليه دي ما في 11 بيتا هيدروكسيليز يا زعيم. 11 بيتا هيدروكسيليز ما بكون معها شوك تايل، فالانسر از بي. تمام. طيب. You are consulted to see 10-year-old girl because of her mother concern about her height. After history examination and specific investigation, you reach a diagnosis and you are counseling the mother about possible complication. So the diagnosis, طبعا it is clear, ما افتكر في واحد ما عارف الdiagnosis. So what is the diagnosis? كده write the diagnosis. What is the diagnosis of this patient? What is the diagnosis? Terminal. Excellent يا نهدة. طيب. So what is the most endocrine? All of these are endocrine complication of these Turner syndromes. What is the most common? هنا اختلفت الطرق. منهم من قال A ومنهم من قال B ومنهم من قال short ومنهم من قال S. طيب. The right answer is short stages. It is a universal finding. All Turner syndromes are short, but some of the Turner syndrome, they may go to spontaneous puberty, so you can catch up them early, and at that time no ovarian failure. But for sure later on, all of them they have ovarian failure, but shorter stature is a constant findings from the beginning. طيب, 4-year-old girl experience abdominal pain regularly at pubertal stage P1 and B1. يعني when you examine her, you find her she's having pubertal stage 1 breast and stage 1 pubic hair. She showed no sign of pubertal development. Ultrasound of her abdomen revealed several follicles in both of her ovaries. What is the most diagnosed? يعني انت جاتك في الاي ار وطلبت الالتراساوند، او انت طلبت الالتراساوند والريزلت اوف التراساوند جات قالوا كتب لك دكتور الريح multiple follicles with cyst around 1 centimeter, follicular cyst. So what are you going to tell the mom? تمام. الجود نيوز most of you they mention normal ovaries. So this candidate does not having central precocious puberty because there is no sign of puberty. It doesn't have autonomous ovarian cyst, yeah, because she is not having even evidence of puberty. So autonomous ovarian cyst usually is a cyst of a size 2 or more, or sometimes 3 or more, that secreting estrogen, and the girl usually present with breast development or even having cyclic bleeding. So it is not an autonomous ovarian cyst. But you have to know that in up to 5% of girls, you may find a follicular cyst, follicle with a cyst usually less than 2 millimeter, and this can be considered as a normal ovaries for prepubertal girl. طيب Yara, who is 2 and 1 month years old, is referred to because of early breast development. Her mother says that Yara's breasts have been developing since she was 1.7 years old. She has had no vaginal discharge. System reviews are remarkable. She is the second child of healthy consanguineous parent. Her mother experienced menarche at 13 years of age, and onset of puberty was normal for her father. Yara present height is positive 1.5 standard deviation, while her weight is positive 1. Physical exam revealed healthy girl with breast development tenorus like 2, no pubic hair. So what is the most likely diagnosis? Excellent. Excellent. في واحد كاتب لي الإجابة شنو للسؤال السابق. الإجابة دي السؤال الماضي. The previous question. The previous question, this is a normal ovaries. طيب. ممتاز. طيب. You saw a 5-year-old boy, his parents was concerned about his secondary aneurysm. His mother mentioned his continent till 6 months ago. Also, she noticed excessive water intake, especially during daytime, but no weight loss. He is the first child. His second brother is 6 months old, healthy, no family history of concern. His exam is normal, and investigation showed normal serum calcium and potassium with serum sodium of 138, urine specific gravity of 110, and RBS of 138. Serum, urine osmolarity is 285. Serum and urine, كله الاثنين. Serum and urine is 285. So what is the most likely diagnosis? عجيبين يا رهيبين انتم. ممتازين. امتياز شديد. طيب, based on this history, the important point in the history you have to concern it. This is a child, he developed this excessive, yani he's having polyuria and polydipsia, but the polydipsia usually during the daytime. His problem starts 6 months ago. He's the second child is 6 months old, and usually this is maybe one of the stressful condition for him. Exam is normal. The serum sodium is normal. Why we measure the serum calcium and potassium? Because as you know, hypercalcemia and hypokalemia is a differential diagnosis of polyuria. Serum sodium is normal. Urine specific gravity is 110, and the RBS is normal because the differential diagnosis is having diabetes or not. And urine and serum osmolarity is normal. So most likely you are dealing with primary polydipsia. You have to consider this differential diagnosis in your mind. طبعا سيد أمير موجود يا جماعة, ما تنسوا المعلومة دي. أمير is very expert in diabetes. يعني ممكن أمير هسه يحتاج علينا يقول لنا يعني ما يمكن يا بشير الناعم يكون partial diabetes insipidus. ما partial. طيب it could be طبعا partial, لكن based on this data most likely you are dealing with a child having primary polydipsia, and this if child you just go, you allow him to be يعني restricted from the fluid for a couple of hours, he will end up with concentrated urine.
تسمح لي يا بشير اعلق على
ايوه طبعا, عشان كده انا ما قلت الزعيم الكبير قاعد.
لا العفو يا اخي العفو. طبعا الجماعه دي لانه هي based on previous teaching and I gave them teaching
بالله انا كل الناس جاوبت صح يا امير.
على دي ام وكده, لكن the most important طبعا انه الباترن, يعني في الام سي كيوز the pattern is clear انه مع primary polydipsia, لكن في some cases فيها overlapping زي ما قال دكتور بشير, يعني ممكن يكون partial DI, في بيكونوا دي بسموها red flags او يعني subtle soft signs, زي مثلا specific gravity less than 10-15 10-10. This can make you suspect انه في excessive loss of water in this urine. برضو having يعني specific gravity of urine less than 100 less than 300 in a context of normal plasma osmolality. This may make you suspect. فديل البيشنت زي ديل احسن شيء انك تعمل لهم طبعا water deprivation test لو كان في severe symptoms of thirsty. لكن otherwise يعني it should be passed as primary polydipsia. I think that's fair enough.
Thank you very much, Amir. Thank you very much for the contribution.
بارك الله.
طيب result which indicate particular diagnosis they already covered by Amir. طيب سؤال 15. السؤال ده لذيذ جدا. وليه؟ لانه نحن في الاندوكراين كلينيك خاصه في السعوديه لانه في lot of obese children بنشوف ريفيرال رهيب عشان هذا الايشو. طيب 11 years old obese child body mass index 34 his parent state our son is very obese and now we know the cause because our local doctor has finally measured the thyroid value and he has found that our son is suffering from hypothyroidism. TSH is 7 and the free T4 is 15.6. This is finding give us great relief. Please treat him adequately so that he will lose his overweight. This scenario كما هو. طيب which of the following statement do you agree with? In obese children, subclinical hypothyroidism with elevated TSH is a quite common cause for obesity. Well, in obese children, elevated TSH level may occur in up to 50%, but T4 level are usually normal. Elevated TSH level are consequence and not a cause of obesity. When obese children, elevated TSH level reverse to normal only after thyroxine. طيب, what is your response? What is your response? طيب, different response, but the majority of you given the right answer. As I mentioned, this is very common. In obese children, you may have slightly elevated TSH, and not only that, even sometimes you may have a slightly elevated free T3, but normal free T4. This is usually a consequence of obesity and not a cause of obesity. Don't refer them to the endocrine. Get sure, yeah, this patient at this stage, most likely he's not having hypothyroidism. Keep in mind, يعني بس انتوا بالنسبة لكم, keep in mind أنه obesity, there is an evidence currently, there is evidence أنه obesity, it can increase the risk of Hashimoto's thyroiditis. But so if the child is having no symptom and just having elevated TSH with a normal, especially if the free T3 the entire side is normal, this is not obesity. What you need to do, just you can follow the patients and ask the child to reduce his weight. If the weight reduced, for sure the TSH is going to improve, and this is not a cause of obesity, rather it is a consequence of obesity. طيب, خلاص يا أمير, this is the last question. question لذيذ جدا, اللي بيجاوب السؤال ده حيكون عنده حاجة رهيبة. You are asked to see a 16 years old girl who has just been diagnosed with anorexia nervosa. Of the following, which is the pattern of endocrine abnormality you are most likely to see? يلا أنا حافتح الشات وأشوف مين أبو الرهابة أو ست الرهابة اللي حتجاوب السؤال. يعني اول سؤال انتصار سالتني قالت لي التي 4 نورمال، انا بس اديت الداتا اللي عندي يا انتصار. تمام، كل منهم ادلى بدلوه، كل منه ادلى بدلوه. طيب ده السؤال ده انا جبته عشان الاندوكراين كونسيكونس اوف انوركسيا نيرفوزا. ان بيشنت هو از انوركسيا نيرفوزا، ده اول حاجه الثايرويد ايشو زي السيك ايو ثايرويد، يعني نفس السيك ايو ثايرويد. التي 3 بيكون في اللور سايد، التي 4 ممكن يكون نورمال، واحده كبيره زعلتني من التي 4، والتي اس اتش بيكون نورمال. So the T3 is low concerning the thyroid. Again, because it's stressful condition and even stage of malnutrition, we expect the ACTH and cortisol to be in the higher side. So the cortisol is going to be in the higher side. And not only that, as we mentioned, if we have high cortisol and high ACTH and the malnutrition itself, this will affect the gonadotropin releasing hormone. So the LH and FSH is going to be low. So I have low LH FSH and I have low T3 and high cortisol with a growth hormone which is high, because this state usually it creates what we call growth hormone resistance. So that growth hormone itself, it will be in the higher side because of some sort of resistance, but if we measure the insulin-like growth factor, it's going to be low. So what you come up from this slide in a child with anorexia nervosa, the endocrine consequence is gonadotropin releasing hormone. Gonadotropin is going to be in the lower side. Growth hormone is going to be high, Y4, because of this stage of resistance. Cortisol, because of this degree of stressful condition and the nutritional issues, the ACTH and cortisol will be high. And the T3 is low, Y4, because this state, it creates what we call Sickle thyroid syndromes. And this is the last slide. What I say, thank you very much for you. Just you can have a view of Medina.